right, good evening. Welcome everybody, and thanks for coming. So I was asked to talk a little bit about some of the things that I do. I do mostly spine surgeries, necks and backs, and try to do as much minimally invasive as possible. So we're just gonna do a little overview. So what does really minimally invasive mean? I mean, if I can spend 3 hours doing something through a 1-inch incision, but I can do it in an hour with a 1.5-inch incision, which one is less invasive, honestly? So there's a lot of things that come into what's less invasive. Is it, the surgical time? Is it a small incision, like I say? Is it a quick recovery? Is it because I use a microscope? Is it because I use an endoscope, which I don't use yet here, but that's sort of coming along in the pipeline, basically. Or just the fact that you have a really low complication rate. If you can do things efficiently through a little bigger incision with short surgical time and a quick recovery, that could be minimally invasive, even though there might be another way of doing it with even a smaller incision. So there's a lot of things that come into that. And also, just to clarify, laser surgery. Everybody asks, is it done with a laser? Well, we have a laser on our X-ray machine that tells us where we're located, but that's about the extent of really the use of lasers in everyday spine surgery. So even with a laser spine institute or something like that, they're not using anything magical that we don't have. That's laser, and nothing happens except a laser goes through you and everything's fine. That's not really reality. So, and then there's, of course, the multifactorial causes of back pain. Everybody gets back pain at some point, right? Some people have it for a short amount of time, other people have it chronically, chronic bouts of it, and there are so many factors that go into back pain. You've got the whole anatomy here. You've got the vertebral bodies, you've got the discs, you've got the facet joints, the ligaments, the tendons, the muscles. It's a complex anatomical area. And honestly, we don't always know. You can present with back pain with a perfectly normal MRI. You can have no back pain with a horrible looking MRI. And most things, they will recover anyway. So you're not going to really get complex imaging or an expensive MRI to know exactly what's causing the back pain. And but there's so many things that can, play into it. And I think I would venture to say that most of the time we honestly can't tell you exactly what it is. So on that note, which person do you think has back pain? And I just kind of tricked you because I told you that you can have back pain with a normal MRI. But here's a beautiful looking MRI, nice alignment, discs are nice, the vertebral bodies are beautiful. And this could be a person that can't tie their shoes in the morning. It could be a person that can't lift anything heavy. Really restricting them and wanting to go for a run. And then this one could be 80, playing tennis, no back pain, does the wood, fills the fire and chops his own cords and everything. And they might just have one little pinched nerve that's bothering, but the back is really not a problem. So that also makes things complicated, is when we don't know exactly the source for some of these things, then what are we going to do to exactly treat it? So can surgery help? For most back pains, surgery is not going to help you at all. That's when you're going to have a little watch and wait time period, maybe some anti-inflammatories. You're going to see your physical therapist. You're going to try to go for a walk, try to keep moving, see your chiropractor, whatever sort of methods you might use heat or ice, depending on sort of how you're feeling. For the most part, you're not going to need surgery for your back pain. And so unless, if there's a little inflammation in your facet joint, it would be rare for me to do surgery on you. If you have just discs that are bulging a little bit, surgery is not going to help you if that could be the cause of your back pain. Some structural things, absolutely. If you have an unstable slip in your back, and I'll show you a picture of that later, that doesn't respond to sort of conservative measures, then surgery is absolutely very likely to be able to help you with that. So we have our anatomy. I'm going to focus mostly on the lumbar region, just sort of to save time. We might come back for the cervical at some point. But you have your 7 cervical vertebrae, you have your 12 thoracic vertebrae, and then you have your 5 lumbar vertebrae down to your sacrum. And this is a pretty normal curvature here. You've got sort of a little cervical lordosis, a little thoracic kyphosis down to your lumbar lordosis. So that's a pretty normal looking MRI. And then, what do you call back pain? So this is one of those things where people will come in and say, oh, my back is killing me. I'm just dying of back pain. And I said, well, where is it? They're like, right here. Right here. And they have no pain in their back or in their muscles. It's really just in the back and a little bit down the leg. Well, that could be because of the sciatic nerve or one of the nerves in the back being pinched. It could also be from the sacroiliac joint. So it's very important to sort of localize where the back pain is, where does it go, does it lead anywhere, when is it? For the most part, is it just in the morning? Is it just when you walk or stand? All of these factors are important. So as far as the lumbar spine is concerned, we can do a lot of good minimally invasive procedures to help when you have a pinched nerve in the back. So a microsurgical discectomy, for instance, if you have a herniated disc, and I'll show a little bit of that again later on. We can do a laminectomy, which means taking a part of the bone, laminectomy, which is we take a little bit less of the bone, medial facetectomy is a part of the joint removed, a whole facetectomy. That's rare that you can do that without needing to at least do some sort of stabilization. And then foraminotomy is sort of, these are all basically procedures that we can do to unroof or make more room for some of the nerve roots. So if you have spinal stenosis, for instance, what kind of symptoms do you have? You might not have any back pain. It's possible to have absolutely no back pain or minimal back pain with spinal stenosis. But you start by kind of starting to lean forward a little bit when you're walking or standing, because it just makes it feel better, because you have heaviness often into the legs, sometimes even pain into the legs. The shopping cart sign is a classic one. You kind of hang on the shopping cart when you're shopping so that you can finish your rounds there. Even weakness in the legs, feels like the legs are just going to give out on you. Some people have numbness or tingling. Sometimes it's just a feeling that they don't describe as pain, but their legs just don't carry them further. They're walking along and then they're just not getting any further. And not because it's horribly painful necessarily, it's just not functioning. And for that, so for instance, a laminectomy or a medial facetectomy can be done for lumbar stenosis. So if you have, and then you can also have a synovial cyst that I kind of threw in there too, which is a cyst from the joint that can also push on a nerve. So here, for instance, you see the spinal fluid coming down here, and then you don't see it. So this is where your spinal fluid is. In the spinal canal, the strands here, I don't know if you can see it well enough, but the strands here are the nerves that are coming down into your feet, and they're swimming in that spinal fluid. Now you can have a spinal stenosis on your MRI report that is true, that it's a narrowing around your spinal canal. That just means, that could mean that it's just narrower than normal, or it could mean that it's really quite narrow. So there's often the severity of mild, moderate, or severe. And if there's enough spinal fluid around your nerve roots, then it's unlikely that you're going to get severe spinal stenosis symptoms. And so I often use the analogy of, like, if you're sleeping in a king-size bed, you've got tons of room, right? You can roll all the way around. There's plenty of room. And if you go to a queen, you still have plenty of room. Even if you slept on a twin by yourself, you know, you're not going to fall off. But if you get really into a small cot, then you're not going to have as much room and you might start falling off. So that kind of an analogy I often use to sort of describe, well, but my report says it's spinal stenosis. Well, yes, that's true. It's narrower than it was when it was perfectly normal or when you were 10 years old. But now it's just a little more narrow, but still enough. So if we do a laminectomy, we're essentially removing, so here's the disc, here's the spinal canal and the nerve roots going out, and the facet joint. And usually I don't remove the spinous process. I leave that in place, and I just go between them and sort of remove a little portion of the bone between them. And then I, using the microscope, go sort of underneath, and I'm able to take the pressure off of the nerves. So usually there's a thickening of this bone here and ligament on top of that. And so the standard approach is the laminectomy full with a long incision, removing the spinous processes, removing the entire lamina. And a sort of a less invasive approach is trying to leave most of the anatomy intact, and letting the muscle come back to the spinous process to attach to it, and just going in between and removing sort of the offending features without going overboard. But sometimes the stenosis is so bad that you really can't leave the lamina. You have to remove it, because otherwise you're not really treating the symptoms. So as opposed to stenosis, the disc herniations, that's when, or you have a slipped disc, people talk about that. That's usually a much more acute problem. Your spinal stenosis, it can come on, relatively quickly, but typically it's a gradual worsening of a mile, and then you can barely get to your mailbox over, sometimes just a few months, and sometimes it's even a few years, where the disc herniations typically are pretty acute. You just sort of, you hear a pop, or you feel a pop, just something happened, and it happened, you can tell me what time it happened, the date it happened, whereas with spinal stenosis, you're saying, a couple years, something, and it's been worsening for the past few months. But usually with a disc herniation, you're going to tell me exactly when it happened, what you were doing when it happened. There can be weakness in the leg, there can be numbness or tingling, even bladder or bowel disturbance if it's a huge disc herniation that almost closes off the canal. And interestingly, even though you may have a spinal stenosis that almost closes off the canal, it's very rare to have bladder or bowel dysfunction with spinal stenosis. And it has likely something to do with the fact of how slowly it just comes on, that it's somehow there's an adjustment that happens, but it's not as quick. Now, most disc herniations, probably around 80% of them, you're not going to need me for. They're going to go away on their own or with conservative measures, and typically they'll do that in about 6 to 12 weeks, something like that. On occasion, we'll actually offer people surgery sooner for disc herniations, and that's obviously if there's bladder or bowel symptoms or a closed off canal, that's an emergency. But there are people that get a disc herniation that it's just cruel and unusual punishment not to offer them a surgery that takes half an hour to do, get the pressure off the nerve and make them feel better, because nothing is working. They're not sleeping, they're not eating, they're crawling on the floor. And even, admitting someone for pain management, they get constipated. It's just, some people just are in a really bad way, and then we'll do something sooner. But we try to support people through the first few weeks, and then usually they'll start to feel better and start to think clearly.
Can I ask a question?
Yep.
Why the bladder or bowel disturbance? How does that have to do with the...
So all of the nerves that go into your bladder and bowel function are going to go right through the spinal canal, and they're going to exit really low. So any disc herniation, really anywhere in the spine, can cause that. You can get that in the thoracic, cervical, and the lumbar. So here, for instance, here's a diagram of where the individual nerve roots go. So when I see patients in the clinic, I really want to know where their pain radiates, because that is super important. As I showed you on the MRI scans, some people, have a lot of degenerative changes, a lot of narrowing around nerve roots that they have no symptoms from. So I'm not going to go in and try to fix their back by fixing their film. I want to fix what's wrong with them. And so, for instance, if you have pain down into the buttock to the outside of the leg, and into your foot, but you have a disc herniation far out along the nerve root, that's L3, that goes into the front of the thigh and into the knee and into the shin, then I'm not going to operate on your fifth nerve. It has to go together. So it's very important to recognize sort of where does the pain actually go? Where does it, where's the numbness, where's the tingling, and does it fit then with the pathology that you see on the MRI scan? So here, for instance, is a disc herniation. So here are the vertebrae, and the spinal canal is here. The white is the spinal fluid, and this whole big hunk of tissue that is in there is a big disc herniation. It's a little hard to see on the axial view, but so this is a quite a large free fragment of disc that's sort of escaped from the L5S1 disc space and gone up. And even with it looking that bad, it could still dissolve on its own without needing surgery. But if it continues, then it's a pretty easy procedure to take it out, get it off of the nerve root, and make you feel better. This is the kind of thing that's typically done through, less than an inch incision, same day surgery, takes less than an hour to do, and it's an active recovery time. So here, for instance, we don't even often have to take a part of the bone, just goes into the ligament, move the nerve over a little bit, and just take that little piece out that's underneath the nerve root. So these are some more minimally invasive access options. So typically, we'll do a midline incision and come down here, push this muscle over to the side, and put a retractor in there depending on what we're doing. We can also, if I have to access something way out here, I can put one of these tube retractors through, it's a half an inch incision, and put it all the way down here to where I need to go without needing to distract the muscle in the middle. And so these are some, you can even do fusions through these minimally invasive tube retractors. And again, that comes then back to, what is actually minimally invasive? Is it less invasive to do 6 of these little ones and take a little longer to do that? Or are you better off with a little longer incision but minimal retraction, quicker recovery time, but the same result? So that's all a matter of sort of what your preference is, how quick you are doing things, and what you sort of, how your practice pattern is. So the microscope is my best friend. And it stands on the floor, and then this is all draped sterile, and I have these handheld that I can move it. It's basically like a little robot. And the eyepieces are, there's 2 of them, so my assistant, if I have a PA or another surgeon working with me, we're both seeing the same thing, and we're both getting incredible magnification and light down into these little holes that we're trying to work through. And part of that, not only getting the light and the magnification, and having also the person that is assisting you seeing so well, because the alternative is using a headlight and loupes glasses, those little, like the jewelers wear. And in those cases, then you're like this, looking down with your headlight, and your partner is here, butting heads with you. And they're not going to see anything, and you're going to be the only one seeing anything. And also, working like this all day, I'm going to need one of those surgeries of the neck. So I can be in a very neutral position doing surgery all day. I'm looking like this through the microscope, and I'm working down here. My shoulders are down, my neck is neutral, It's a much more comfortable way of doing things. So this is very crucial. And so what are we talking about as far as surgery? So most of the time, if you have one pinched nerve, or 2 even, 2 levels, 1 or 2 sides, that's bothering you and it hasn't gone away and you're going to go ahead and have surgery, most of them are less than an hour to do. And it's same day. You're going to go home the same day. There's usually the the blood loss is very minimal. It's rare to go beyond, or always less than 100 typically. Even 10 to 20 cc's is not unusual. And it's an active recovery time. So you're recovering from a small incision and a little bruised feeling in the back. And but you're supposed to be able to get up and walk around, and if you go to the bathroom and get yourself something to eat, and maybe not do the firewood that day or the next day, but give yourself a little bit of a rest as far as heavy lifting. But typically it's a very quick and good recovery time, barring any complications, of course, which are thankfully very, very rare. So here's another thing, antrolisthesis. So this is someone that has a slip. And again, just because they have this doesn't mean that they need surgery, but if they have a pinched nerve around it and it's unstable or it's progressive, then surgery can become an option. And this could cause both back and leg pain. Sometimes if there's just leg pain and it's pretty stable, I'll just do a microsurgical decompression of just one of the nerves, for instance. But if it's unstable and progressive, then we'll do what's called a decompression and typically a fusion then to stabilize it. And that has really, there's different types of doing fusions. Anterior interbody going from the front, going from the back, going from the side, pedicle screws. There's different ways of doing a fusion. Or just putting bone on leg too, without any instrumentation. Those are all options. And so these are sort of an example of some of the strong constructs that you can do. You can put a cage into the disc space to maintain the height so that it doesn't collapse, or to make more height in order to make more room for the nerve root that's going to go out here. And then you can put screws through the bone and a little rod on each side to